Professor Noakes, have you ever received any information or any guidelines from the Health Professions Council in respect of social media and the use of social media?
No, I haven't, and to my knowledge, no such rules exist or guidelines exist.
Professor Noakes, in the course of your evidence, which lasted a number of days at the last sitting, you spoke of the metabolic syndrome and insulin resistance and diabetes. Would you be able to tell Madam Chair, expand on that a bit? Is there anything else that you wanted to speak about there?
Indeed, Madam Chair, since we last met, we published this paper in the South African Medical Journal, and it was work that started in about 2011. So I was aware of this information prior to the trial commencing. And the publication is this, and it's called A Successful Lifestyle Intervention Model Replicated in Diverse Clinical Settings. It's a group of authors. The senior author is, in fact, Dr. Du Toit, who I'll introduce you to, and I'm the third author. So this study started in about 2011, and the idea was that these people, Dr. Du Toit went to Canada, to the small part of Canada, small community in Canada, noticed everyone was obese and decided to do something about it. And he'd heard about the high-fat diet, the low-carbohydrate diet, and because of his interest being a South African, he decided to introduce this as one of the components of a lifestyle intervention program to help perhaps reverse the condition. So this is Dr. Du Toit showing you what he does, that he works with groups of patients, not with individuals. And it's really interesting to work out how did the trial come about, because it's not a standard protocol, it's not a randomized controlled trial. And we have to defend it because it's not a randomized controlled trial. So he said, as a physician, you give prescriptions every month for chronic conditions and you don't see any improvements in health. Actually, things tend to get worse over time. And this is a young doctor speaking about his experiences in modern medicine. So we started to question, as physicians practicing recommended guidelines, why aren't we seeing the desired improvements in health? Why is evidence-based medicine not working? So that is a question that every single doctor should be asking. But it takes a young doctor from South Africa to go in the extremes of Canada to ask that question. And we'll also ask, why did it take him to ask the question? So we started these group-based lifestyle interventions with obese, pre-diabetic, diabetic patients, and we tracked their patient outcomes with the electronic medical record data, practice-based medicine. So what they were doing was that they would examine the patients on the introduction to the program. They would take a whole lot of measurements, and then the patients would be monitored and assisted to get better. The key was they were going to try things that made patients come better. They weren't doing a clinical trial to see if this worked or that worked. They found out what worked, they introduced it, and then they amplified it, and they kept reintroducing it. And what we found was participants' health improved, they reduced their need for medication, and their control improved, and then things took off from there because people became really interested. So that's how they did it. It's not a randomized control trial. They took every single patient who wanted to join the program, they took them on, and that trials don't do that. And why this is important is because as soon as you introduce a control group, you have to spend a lot of time on the control group making sure that there's only one thing differing between the two groups. What they were able to do is put all their efforts in the one group. And why? Because why do you need a control group if my profession says these conditions are irreversible? Why do you need a control group if that is what what we say in medicine? We teach patients with a metabolic syndrome, you must take your medicines because it's an irreversible progressive disease. So why do you need a control group to prove what is standard advice or standard statement? And that was roughly the diet that we put them onto, and that is described, and I don't think we've shown you that, but the point is, it is there, yes. So they were initially put on, admittedly, a low-fat diet, and then they were moved onto the high-fat diet. And the reason is, when you're initially losing weight, you are in fact on a high-fat diet because you're burning your own fat stores. And what we wanted to do was to make sure that the calorie consumption came down. And you can do that by reducing the fat content. But then you must reintroduce fat to make sure that people don't become hungry. And that was where they came to me, because they said the people are hungry. We've got to take the hunger away. And that was the point, that you have to increase the fat consumption. So although you potentially increase the calorie consumption, you take away hunger, and that, as a consequence, people eat less. So these are the data of 139 of the patients. In the end, we had data for 382 patients, but these were 139 who had the best follow-up, and there were subdivisions of the trial, and this was the most complete data that we had. And so if you look at the baseline data, we've got age, we've got sex, height, weight, body mass index, and you'll see the body mass index at start is 35. That's way into the obese range, 30 years obese. Then percentage with elevated waist circumference, percentage with metabolic syndrome, and I draw your attention to that. That's 57.6%. Remember, this is an irreversible condition. That's what medicine teaches. This is an irreversible medical condition. Then those PHQ factors have to do with happiness and so on. Then there's blood pressure, which is at the high normal range. High density HDL cholesterol, won't worry about that. LDL cholesterol is actually quite low. It's relatively low. But triglycerides are high. We want those values below 1. That's high. And then the fasting blood glucose, which should be down at 5, is 5.9. So these people have advanced insulin resistance and prediabetes. And the HbA1c tells us what the average blood glucose concentration is during the day. And with a value of 7.4, it's probably the average glucose is 8. Now we want the glucose to be 5. It's about 8. So this population is in fact profoundly diabetic. So all we do with these people is we put them on a high-fat diet and other interventions, but the predominance is the high-fat diet. And let's see what happens after 6 months. Their weight comes down, body mass index comes down, the percentage with elevated weights come down. And look at this, metabolic syndrome goes from 57 to 20%. This is an irreversible condition. And we reverse it by putting these people on the diet that we are told is harmful. And if you go back to the letter that was written to the Cape Times by the Dean of the University of Cape Town Medical School, who's now the rector of Stellenbosch University, he said this diet will damage the health of adults if you put them on it. And we are the first people in South Africa to provide absolute evidence for a diet that works. And that's the difference. This is a diet that works. And all the people who have complained about me over the last 5 years, not one of them has evidence that their diet is healthy. Not one. Not one has done an intervention trial. And we've done the intervention trial, and it works. So anyone who tells me that this high-fat diet is dangerous, it must be dangerous in those people who are the sickest. And it's the opposite. They become healthy on the high-fat diet. And you know what that proves? That proves that the diet they were eating was the problem. That's what it proves. The high carbohydrate diet that these people were eating was the cause of their metabolic syndrome. That's what these data prove. So their blood pressure comes down, 136 to 122, the average. HDL cholesterol goes up, we want it to go up. LDL cholesterol. You've probably heard testimony that when you put people with metabolic syndrome on a high-fat diet, the cholesterol goes up. It did not. In this trial, it came down, as it has to, in most of the patients. Triglycerides came down, and remember we spoke that triglycerides are a key marker of insulin resistance, and if they're elevated, you're insulin resistant. The fasting glucose comes down, and the HbA1c comes down to some extent, not as much as we would like it to. This group is they're still not healthy, but they're a lot healthier than they were. Now, I would put it to you that if this was a drug, people would be signing up to give us the Nobel Prize, because this effect is profound. We've affected every single risk factor for heart disease on this diet. And it's a diet, and that the diet did it. And I might also mention that most of the patients go off their drugs on this diet. So, this effect is utterly profound. What happened? Did anyone take any notice? Barely. Why? Because no one's going to make money out of putting people on a high-fat diet. So, I submit that these data produced by South Africans in Canada prove that it is the high carbohydrate diet that is causing the metabolic syndrome. And I gave all the biological evidence for that. And now we've got clinical trial data to confirm that. And that anyone who says that putting people with a metabolic syndrome, who are the sickest people in the population, on a high-fat diet is going to harm them, we have provided evidence. And again, I emphasize that those people who accuse me of giving an unhealthy diet do not have data themselves. They have not gone out and done the trials. And the first thing you should do, perhaps, before you complain about a diet is maybe you should do your own trials to prove that your own diet is healthy. And no one has done that. They've not chosen to do that. So these data show that the metabolic syndrome can be reversed by a high-fat diet as part of a lifestyle intervention program in those with insulin resistance. And this outcome is not produced by the conventional medical management using standard pharmacotherapy according to the traditional guidelines, the conventional guidelines. So the story was picked up, and this is rather a nice story by a writer in Britain who read the story and wrote this blog on it. And he is an elegant writer on medical matters. He may not be a doctor, he may not be a professor of science, but listen to what he wrote. He said, "This initiative comes from a self-styled ragtag band of clinicians and data geeks in northern Canada who've thrown away the rule book and started from scratch." And why did we do that? Because we didn't have the money. We didn't have the $10 million that were needed to do this study. We did it on a shoestring. It cost essentially nothing to do this trial. Questioning the official guidelines, they have begun gathering evidence on what does work in the real world. What works in the real world, that's the key. The trial is the first report of what they have found. Their approach is right at the other end of the spectrum from conventional evidence-based medicine, which relies on a hierarchy of methods with the randomized controlled trials at the top. So those, the randomized controlled trials, are the research equivalents of dreadnought battleships on nuclear submarines, massive, hugely expensive, and taking years to build. In theory, their statistical firepower allows them authoritatively to distinguish between what works and what doesn't. But when it comes to providing a reliable guide for doctors on how best to deal with the diabetes epidemic or diabetes epidemic, there's little evidence to show the system has worked. It hasn't worked. We've had all these meta-analyses and randomized controlled trials, and the obesity diabetes epidemic just continues to grow. By contrast, these research mavericks are more like small and highly mobile special forces units operating behind enemy lines. They've jettisoned the idea of a formal hypothesis, rely on fairly simple statistics, and make limited use of control groups. Most heretical is that the number of variables they include can't possibly all be counted for. So it's not just the diet, there are other factors as well. It's a brave and quixotic venture. The firepower and finance of an industry uninterested in lifestyle options is formidable. And that's a key point. The firepower and finances of an industry uninterested in lifestyle options is formidable. Which industries are those? Of course, they're the pharmaceutical industry, which is threatened by any lifestyle interventions that work. Research published in the British Medical Journal this week revealed that in 1 year, companies making diabetes drugs paid an astonishing $100 million to the doctors who prescribed diabetes medication in just 306 American hospitals. And what I'm going to show you shortly is that new evidence released within the last 2 months shows that that medical treatment does not work. It doesn't work. Patients treated with insulin, it makes no difference to their outcome. And insulin is one of the biggest selling drugs in medicine. And I'm going to give you the firm evidence that it makes no difference to the outcome in diabetes. The money was for hospitality, speaking, and consultative fees. And why were they given those money? Because the drugs don't work. So they've got to be bribed to prescribe drugs that don't work. The payments correlated with a much higher prescribing rate of the paying company's drugs. This, the article stressed, did not prove causation. Still, poorly equipped guerrillas have defeated imperial armies in the past. In his article, Professor Ioannidis, who we'll come to later, hopes that they will again. And this is what Professor Ioannidis, who's an absolute genius, professor of medicine at Stanford University, writes. I'm still fantasizing of some place where the practice of medicine can still be undeniably helpful to human beings and society at large. His implication is that perhaps medicine isn't as helpful to humans as it might be. Does it have to be in a very remote place in northern Canada close to the Arctic? And that's exactly where that trial took place. And he wrote that article about 2 years before we did it. And he concludes just maybe.